What brings us here? To this place with the coldest winters and hottest summers? We don't come here to retire. We come here to live, to be challenged, to be inspired. This is a city that demands fresh thinking and duly rewards it. If you can make it here, well, you know what they say. We New Yorkers, we're always pushing ourselves to be better. No wonder this city gives us the best of everything. You don't have to look far to see it. It's all around us. The best food, the best music, the best medical care, the best train station. At NYU Langone, we're collaborating on every level to be the best we can be for New Yorkers and for everyone who seeks our care. After all, we're New Yorkers too.
Hello, and thank you for joining us on another episode of Women's Health Watch, a show brought to you by NYU Langone Medical Center. I'm your host, Dr. Eva Kosta. I'm a cardiologist at the Joan H. Tisch Center for Women's Health at NYU Langone Medical Center. Today's great health topic is rheumatology. That's right, a topic we do not talk enough about, and we are very happy to have with us today Dr. Stelios Viennas. Dr. Stelios Viennas, thank you for joining us. We're going to talk about osteoporosis today, which is very important.
Thank you very much for having me on the show.
Thank you so much. We thought it would be important to bring a show to women about health. We don't talk about health enough. Tell us a little bit about yourself, Dr. Stelios Viennas. Where's your practice? What kind of practice do you have?
My practice is in Astoria, Queens. I've been here in Astoria for the last 15 years. I trained at St. Vincent's, which is actually closed now, and I did my fellowship there and in Westchester County Medical Center in rheumatology. So
today I thought it would be a great topic for women to be aware of osteoporosis. Can you tell us what osteoporosis is? What is osteoporosis?
So osteoporosis is a silent disease, actually, and it is a disease process that basically is bone loss that happens with age. And that's really a natural process. And it happens to different people at different ages. We do see it mostly in women, especially after menopause.
Are there any symptoms, are there any warning signs for women that they have osteoporosis?
There's really no warning signs because it's not something that you feel pain with. Patients who have severe osteoporosis may have some pain, but for the most part, there's really no pain involved, so people would know if they have osteoporosis or not. So that's where testing is very, very important in this disease process.
And then, of course, there's osteoporosis and osteopenia.
Right.
So what's the difference between the two, and is one better than the other?
So according to the World Health Organization, we have a way of measuring bone density, and we can talk about this a little bit later, but there's actually scores that measure bone density, and when a bone density is done, there is, it's the definition of bone loss, which that signals osteoporosis, is about 25% bone loss. Mm-hmm. So that would be osteoporosis by definition. Now, osteopenia is really bone loss, but not quite enough to call it osteoporosis, and not quite enough to have the degree of risk, of percentage of risk of fracture, bone fracture, that you would have as much as you would have with osteoporosis.
So who is at risk for osteoporosis? Is it only men, only women? Is it also men? Because we really think of it as a female disease, but we're also hearing that men can get it too.
So the interesting thing, we know, of course, when women go through menopause, what happens is you lose estrogen, and estrogen is basically, or you lose the amount of estrogen you had, the levels, and so you end up having less estrogen, which is a maintenance hormone for many of our organs, including bone. It keeps the joints lubricated and bones healthy. So as you lose estrogen, what happens is the dynamic process of bone remodeling also changes a little bit. So what's happening is there's a greater acceleration of bone loss as opposed to bone growth. And that happens a lot more in women than it does in men, but we do see it in men as well. But we don't have an actual, by definition, rule with men, just because men don't really go through menopause as we know it with women. So there are other ways of measuring hormones with men as well, but we do see it mostly in women after menopause.
So in women, a lot of it is estrogen, a drop in your estrogen levels.
Correct.
In men, it would be testosterone?
Correct.
Okay, I see. Are we all destined to get osteoporosis, or can we prevent it?
I think some people are more destined than others, and there may be some genetic predisposition too. I think there's also in women who are actually pre-menopausal or who have normal menses can also have osteoporosis, and that has to do with their weight. If they may be very thin, they may be predisposed to osteoporosis. So there may be genetic predisposition with hormonal imbalances there. But in terms of prevention, I would think about testing as early as possible, which would be in their 50s, I would guess, with bone density.
Early would be in your 50s?
Yeah, I would say about 50 years old or after menopause. Some women go through menopause after 45 years of age, or some people have hysterectomy. Some women have hysterectomies before, or especially complete hysterectomies. And I would think that those women should be also tested.
So tell us, how do you measure osteoporosis? What are the mechanisms for measuring it?
So as I was talking to you before about bone density, it's basically a machine that shoots a beam, which is it's sort of like a laser beam through the bone.
It's painless, right?
It's painless, completely painless, and it's probably about one-fifth of an X-ray in terms of radiation. It's very, very minimal at best.
Okay.
And basically that measures the bone density of how thick the bone is, and that's actually transcribed into a number, which goes into a database, and that gives us a certain score. And that score measures whether you have bone loss or bone health.
I had a bone density. It was very quick, and it was easy.
Yeah.
I had no idea it would be so easy. So where can one get a bone density test, and what part of the body do you test?
So a bone density test, now we have new machines. So there are some bone density tests that are exclusively hip. They do the hip and usually the lumbar spine. But now there are much more sophisticated machines that do other parts of the body, such as the forearm, the whole spine, which may be very, very useful, and both hips, which is very useful, especially in patients who have chronic osteoarthritis of the lumbar spine. And it's very difficult to measure bone density because the lumbar spine, if there is a lot of osteoarthritis, then the bone mass may be too thickened, and that may give you a false negative test.
So you should definitely do the hips, but if you have lower back pain, you should do what other part of the body?
I would probably do the forearm.
So if you have osteoporosis or osteopenia, is it difficult to heal if you have a fracture? Does it affect the healing process?
For sure it does, especially if you're not treated. So I would say what happens is a lot of the patients who discover that they have osteoporosis can be from a fracture that they sustained, and they didn't know that they had osteoporosis. Actually, they weren't tested. The other thing is that there's a little bit of a gray area on patients who are osteopenic. In other words, they haven't quite made the mark of osteoporosis. So actually, those people who are osteopenic still have enough risk of fracture that they can actually fracture, and they may actually have to be treated.
So let's focus on the elderly just for a moment, because I know fractures can occur in all age groups, because many of us have had relatives that have fractured their hips. Now, what is it? We all hear about 50% mortality with hip fractures. What is it exactly about a hip fracture that causes people to be at increased risk of death?
Well,
because they heal, right?
Right,
yeah.
Right. They do heal, but the problem is hospitalizations and surgery and complications. I think that's really where the mortality issue comes in. So in a patient who is diagnosed with osteoporosis, an elderly patient who's diagnosed with osteoporosis who is being treated and falls and has a fracture, no matter what, you still have this risk factor of morbidity. But diagnosing a patient earlier might be able to increase bone density. So therefore, increasing bone density will decrease risk of fracture in terms of falls.
So what can we do to increase our bone density? What are some things we could do, starting from, we'll go about diet, medication, exercise. Tell us, what are some things we could do?
So, okay, if a patient comes to my office and we do a bone density, elderly patient, we do a bone density and we diagnose that the patient has, he or she has, mostly she, I would say, has osteopenia. So it depends on the amount of osteopenia that the patient has. If the patient has about a moderate amount of osteopenia, my recommendation would be daily exercise, which is basically stretching. I think we talked about that earlier. Stretching and lunging and push-ups against the wall. Exercises like that stretch your body and actually stretch the tendons, and you're able to stimulate bone growth. So that would be just a natural way of doing.
But an elderly person can't lunge. I mean, I could barely lunge.
No, that's
right.
true.
So what can we tell an elderly person to do for exercise? Someone who's 70 or 75 or even 80 but active.
So an elderly patient who has, what I recommend to my patients is, and I actually write prescriptions to them sometimes to go for physical therapy, to increase to do range of motion exercises and stretching on their own, and to be taught by physical therapists. So that's one thing. The other thing that you can do is supplement calcium and vitamin D, which is very important. Some people have shied away from overprescribing calcium and vitamin D, but we are still in agreement that patients most likely are benefit by taking calcium and vitamin D, at least 1,000 to 1,200 milligrams of calcium and at least 800 to 1,200 units of vitamin D a day. Also, dairy products are recommended. Now, if patients are lactose intolerant, there are other ways to get.
So which dairy products do you recommend?
I recommend
Greek yogurts.
I recommend Greek yogurts, whole milk. Some people do want to do 2%, which is fine, but I do recommend whole Greek yogurt or whole milk, because I think that they need everything in terms of the calcium content.
And if you're lactose intolerant and you have bloating and discomfort with lactose products, milk and yogurt?
Right, so I would probably stay away from that. There are juices out there, like fortified orange juices, fortified with vitamin D. There's also green leafy vegetables that they can have, which are very, very rich in calcium. Also, nuts or cereals as well contain a lot of calcium.
Does meat have calcium?
Meat has calcium as well.
But we all know we should shy away from meat, so be better off with the leafy greens.
Right, lean meat.
How about fruits?
Fruits are very important too. Yes, a lot of them have calcium. I think bananas also have calcium.
So a healthy diet could supplement the calcium. And do you think, is it better to take calcium pills or to take calcium through your diet? What's more effective?
I recommend both, so you can decrease the amount that you take over the counter. It also may be, since we're talking about calcium supplementation, there's calcium carbonate and calcium citrate. Some people have a problem digesting the calcium carbonate, so I do highly recommend calcium citrate also for patients who have failed or are not able to take calcium carbonate.
So calcium citrate for those who can't tolerate calcium carbonate.
Correct.
So now we're going to cut to a video and see what our community knows about osteoporosis.
It's lack of calcium.
The cold weather attributes to osteoporosis because it's the bones. The bones get brittle.
It's from lack of calcium.
Well, it could be not in my family, but it's a hereditary condition that is passed down to mostly females. It's more prominent in females.
I believe my sister, and she had an operation in both knees.
Yes, everybody should go for a bone density test. It's usually your medical insurance will cover it, and they check to see, how you're doing. If you have arthritis, if you have, everybody should go and get it checked.
Yes, couple of times, and I take the test every year.
It's very good to take a multiple vitamin, and vitamin D is very good for the bones, especially. And it's good to get a blood test every few years to see what you're lacking.
Yes, I take calcium every day, eat bananas, and healthy food.
Well, I try to at least walk a few miles in good weather.
Yes, I just come from the gym now.
Well, it depends. It's possible, but if it's in your family genes, it might not help. But it can't hurt. It's still better to do exercise than sit in the house all day.
Yes, that I know. That's why I keep going 3 times a week.
Calcium, yeah. Milk, protein, I would imagine too.
Yes, the bananas, tomatoes, and the vitamins. It's for the calcium.
Calcium. You have to check your calcium too to see if you have too much calcium. But milk, dairy products, if you're allergic to calcium, there are other things you have to talk to your doctor. There are other things that you can take.
Well, milk is good for your bones, but I have to drink lactate milk instead of regular milk. And vegetables, certain vegetables. You know.
Well, that was interesting. We'll talk more about the comments when we come back from commercial break.
More than 8 million people live right here. 27,000 of us for every square mile. That's a lot of people. What makes this city such an attraction? What makes this place so cool? We take pride in saying, I'm a New Yorker. And that's the way it's always been. One thing we've all learned in recent times is that no matter what life throws at us, we face it together. And we always come through, stronger than before. We are, for the most part, good people. We come to the aid of others, willing to lend a helping hand because we care. Even though we sometimes get the impression we don't. At NYU Langone, we're here to care for our fellow New Yorkers and for everyone who needs us. That's what we do. That's what we love to do. What brings us here? To this place with the coldest winters and hottest summers? We don't come here to retire. We come here to live, to be challenged, to be inspired. This is a city that demands fresh thinking and duly rewards it. If you can make it here, well, you know what they say. We New Yorkers, we're always pushing ourselves to be better. No wonder this city gives us the best of everything. You don't have to look far to see it. It's all around us. The best food, the best music, the best medical care, the best train station. At NYU Langone, we're collaborating on every level to be the best we can be for New Yorkers and for everyone who seeks our care. After all, we're New Yorkers too.
Welcome back to Women's Health Watch. For those of you who are just tuning in, joining us today is Dr. Stelios Viennas, and we are speaking about osteoporosis. So that was quite interesting. A lot of people are educated about osteoporosis, but that brought to mind a very important question, checking vitamin D levels.
Right.
You were discussing that when we were watching the video.
Actually, we started doing a lot of vitamin D levels when we were giving intravenous reclass, which is a bisphosphonate, and we can talk about the treatment a little bit later. But we were checking vitamin D levels as a routine, and we found a lot of people having low vitamin D levels, incredibly low, down below 20 or perhaps even 10. The normal levels between 30 and 80, I believe. So that is a problem, and that's a big problem in terms of bone density and bone density loss. And that, I think that happens in bigger cities, especially where people are not really exposed to the sunlight. And I think there's also an epidemic in younger children who are constantly on the computer and not really going out to play as well. I think that there have been some studies where they found that children actually have had low vitamin D levels who are in big cities. So that's a big problem. So supplementation with vitamin D is very important, not over-supplementing it necessarily, but I think the 1,000 units a day may be a little bit short for people.
Vitamin D3, not D3.
Vitamin D3, yes. 1,000 units a day, which we were prescribing before, and I did mention that before. I said that conservatively, but I think if you check a vitamin D level and the patient has low vitamin D, it may not be a bad idea for the patient to take even up to 2,000 units a day. So that's actually very important too.
And the only source is really sun. You can't drink enough milk and you can't eat enough fish
Right.
to get vitamin D. It's
Right.
hard to supplement from the diet. That's patients that just ask me, can I drink enough milk? And not really, right?
Right. And the other thing that I wanted to mention regarding the video is, somebody mentioned about doing a bone density. I'm doing a bone density every year. I think realistically, that's just not allowed by insurance companies. I think just living in the real world, it's just not, it doesn't get paid. So basically, bone densities are allowed usually about 50 years of age or after menopause, and usually every 2 years. Now, some patients that I see in my practice who may have a normal bone density or who come to me for an evaluation of osteoporosis, and we do a bone density and their bone density is really normal or very mild osteopenia. It depends. It's really a call, an individual call. You can also do a bone density if you think the bone density is really good. You can do a bone density in 3 years from now or 4 years from now. It really just depends on the patient. If a patient is her or his diet is good and they exercise, that's something you can individualize to the patient.
So what are some situations that cause younger people to have osteoporosis, not just genetics, but some diseases or medications? What are some red flags for you where you have to screen earlier?
Right. So patients who have chronic diseases, especially chronic inflammatory diseases like lupus or rheumatoid arthritis or Crohn's disease, anything like asthma, anything that has to be treated with steroids or have a chronic inflammatory process will probably cause bone loss. And also because of what we treat the patients with, especially those patients with chronic inflammatory diseases like prednisone. We know that patients who are on prednisone can develop osteoporosis much, much quicker. So these are the patients you want to screen much earlier, and you may even want to treat. You may want to put these patients on calcium and vitamin D, even if they're 30 years old or 25 years old, or even do a bone density for these patients.
What about young women who get Hashimoto's or Graves' disease, thyroid
Even
disease?
that, those are hormonal processes. The thyroid can actually speed up osteoporosis if you're hyperthyroid or even hypothyroid. So both of those processes can actually speed up bone loss.
So younger women have thyroid disease, asthma, things like lupus or Crohn's disease, any kind of chronic inflammatory disease should get screened early, at least asked to be screened.
Yes.
So primary care physicians would be key to this, correct?
Absolutely.
So,
absolutely. I think definitely the primary care physicians are in the forefront and in the front lines really, and they really have to stress that. I think that's so important because it is a silent disease and a silent killer, as we know. So I think in order for us to better diagnose it, we have to do more testing at an earlier age, especially on patients who have chronic illnesses.
and people are more aware now, they read about it on the internet, so patients should advocate for themselves. Ask for bone density tests if you are one of these people at risk, or if your mother had osteoporosis, or aunts or sisters, like that woman whose sister had osteoporosis, who didn't realize that she's probably at risk.
Exactly.
Right? And ask for vitamin D test.
Right.
Now tell us about treatment, because that's a big topic.
That's a big topic, and it's very interesting. I think I was talking to you about this before, that I probably treat osteoporosis a little bit different than I treated 10 years ago, and most of us, whether in the endocrine field or rheumatology field, we're treating it in a different way. As you know, the medicines that are really the forefront medications are called bisphosphonates, and they've been around for a long period of time, like Fosamax and Actonel and Boniva, and these are probably names that people have heard. And these are mostly oral medications that are usually taken either once a week or once a month. They're not easy medicines to take, and they are actually, you have to take them on sitting up and not laying down, because they can produce or can cause esophageal irritation. And so it's very, very important that you do it the right way. And the thing is that it has to be in an empty stomach with most of these medications, because the absorption of those medicines is minimal at best. So also, according to the pH of the stomach of a patient, it really depends on how much of this medication is going to be absorbed and how much is going to be effective really in the treatment of osteoporosis. So a lot of the patients who have problems with their stomach, either esophagitis or chronic reflux disease, are really not able to take these medications. They're very difficult to take. So there is another medicine called Reclast, or zoledronic acid, which is actually the same type of medication, but it's given intravenously, and that is once a year medication. So not everybody can have this medicine. Usually insurance companies ask to see if you have a predisposed condition such as esophageal reflux and you're not able to take that medication in order for you to take the intravenous infusion. We do think that it's very effective to take the medication intravenously because you do get 100% absorption. The possible side effects for these types of medications can be either an allergy to the medication, you're not able to take that medicine because you develop hives or rash or whatever, or stomach irritation, or sometimes, especially on reclass, you can get generalized bone pains and or fever, flu-like symptoms with the first infusion usually. But really, that's the extent of the side effect profile. Also, patients with kidney disease are really not, with severe kidney disease, cannot really take that medication. So that would be one class of medicines that we use. There's also another class that we use, not so much now, which is not a very effective treatment necessarily, called myocalcin, which is a hormone, calcitonin, that we do use that as a nasal spray or even an injectable. And that we don't use very much right now. It's not as effective as the new medicines that we have. But sometimes I do use it on patients who have bone pain from a vertebral compression fractures, because usually that pain is very severe. And that calcitonin can actually decrease bone pain. So sometimes I prescribe that in combination with a bisphosphonate if I'm treating a patient for a bone fracture or osteoporosis who sustained a bone fracture. So so that would be one class of medicines. The other class of medicines, which is a little bit more sophisticated, is called Prolia, which is basically a biologic medication. It's not a drug. It is a biologic medicine, which is basically a protein which is injected every 6 months, and that protein is an antibody against a specific protein that stimulates the osteoclast, which is the bone, the cell that breaks down bone. So then the osteoclast gets inhibited from breaking down bone, since that protein is not going to bind to it. So the major possible side effects of this medication is that it is a biologic, and some patients can have reactions to the biologic, whether it can be either an allergic reaction to the injectable part, or where the injection is going to be made or done, and also possible infections, because it is an antibody, it's a monoclonal antibody, so it may reduce the immune response, and people can get urinary tract infections or upper respiratory infections. Probably a low percentage of patients. So there will be new agents that are going to be more likely closer to the biologics that are going to be coming out in the near future regarding treatment. That's probably going to happen in the next couple of years. So actually it's looking very good. In terms of treatment and results in treatment, I think bisphosphonates are very good medications, and Reclass is a very good medication. It does help bone to produce new bone. The only thing is with Reclass, we do not have a good sustainable bone growth over 3 or 4 years. It kind of drops off after a year or two. With Prolia, it seems to be going further, which is a good thing. So, I think we do have very good treatments right now. I think the most important thing is to screen patients and diagnose patients in order to treat them.
Can you reverse it with treatment? Does it completely reverse, partially reverse?
So it really
stop it from progressing?
That's a very good question. So it really depends on the amount of osteoporosis a patient has. I think with Reclass or the bisphosphonates, you may see some reversal or bone growth, or you might see the numbers decrease. Probably not. It's not going to be. It's not going to be a perfect amount, and neither is it going to be with Prolia. But it may be better with Prolia than it is with the bisphosphonates at this point. But I would think reversal, it really depends. I think if you have mild osteoporosis, you probably can reverse it and then just monitor it.
What about osteopenia? If you're lucky
Yeah,
enough
in terms
to
of osteopenia, the thing is that now things have changed. I think that's why I said things have changed like from 10 years ago, because 10 years ago we used to treat patients actually for osteopenia as prophylaxis. But I don't think that's happening from a lot of people right now because we're afraid of possible side effects, especially with the jaw necrosis, which has been reported, especially on patients that usually are on immunosuppressive therapies or have chronic inflammatory diseases or have really bad dental illness.
So the people who are at risk for jaw necrosis are the people who you said you have chronic illness, poor dentition, like bad oral health,
Correct.
and what else?
People who are on immunosuppressive drugs, who are chemotherapy patients, who are cancer patients.
Those people should not get the bisphosphonates.
Well, it really depends because actually the bisphosphonates may be a treatment for them in their cancer treatment. But the thing is, yes, those people we should be careful on what those people who are getting actively chemotherapy.
What about the bisphosphonate holiday? People who take some doctors give their patients the bisphosphonate holiday. They put them off for a year or two and then start them again.
I think that's a great idea, especially, and you can pick up from at any point in terms of bone remodeling. I think that's a good idea, and I do that with some of my patients as well. As long as the patient does not have severe osteoporosis. And I usually don't treat patients with bisphosphonate for more than 5 years. I think that if the bone density has not really improved in 5 years or a great improvement, then it's time to switch therapy.
Okay, and you supplement, when you give these drugs, you should supplement with calcium and vitamin D
yes.
at the same time. That's important.
And exercise. I always stress exercise to the patients. Of course, there are patients who are homebound, who are not able to move. There's obesity involved and other issues where patients are not really able to move. So,
how much exercise for osteoporosis? I mean, we have a set amount of exercise we recommend for heart disease. How much exercise do you recommend for osteoporosis prevention?
I recommend exercise at least 5 times a week.
5 times a week, how much? 10 minutes, 5 minutes?
10 to 15 minutes.
10 to 15 minutes of certain exercise in your home
Stretching
can prevent
is very
bone
important,
loss.
yes.
So is it aerobic exercise, muscular, weightlifting, what stretching? You said
muscular and weightlifting, I would say. And in terms of weightlifting, they could do free weights, which are basically you don't have to go to the gym to really get free weights. You can get little tiny weights at home and do them at home. You can
bands? Bands? You can
correct.
also do
Bands actually is a great idea. Yes.
And you
because that's resistance exercise. That's very good.
And you mentioned that sometimes a lot of stretching will stimulate, by the ligaments pulling on the bone,
On the bone,
stimulate
bone growth.
So we're going to cut to another video and see what other questions we have.
Okay, great.
Smoking cigarettes has long been known to have detrimental effects on the body. However, recent research has also shown that smoking cigarettes has significant effects on bone health as well. Several research studies have identified smoking as one of the major risk factors for osteoporosis and bone fractures. Osteoporosis is a condition of which bones weaken and are more likely to fracture. How does smoking affect bone health? Smoking increases the risk of bone and joint fractures. Smoking reduces blood supply to the bones. Smoking slows down the production of bone-forming cells. Smoking reduces the protective effect of estrogen replacement therapy in the body. It takes more time for bone fractures to heal in case of smokers than non-smokers. One may also experience several complications during the healing process. Smoking may double the risk of rheumatoid arthritis in menopausal women. Exposure to secondhand smoking during childhood may also increase the risk of low bone mass in later life.
My question to the doctor: if I am a smoker, does that increase my chances of osteoporosis?
Can smoking during your teenage years lead to osteoporosis in later life?
Does smoking increase my chances of getting fractures?
Well, that was interesting. We'll talk more about the comments when we come back from commercial break.
More than 8 million people live right here. 27,000 of us for every square mile. That's a lot of people. What makes this city such an attraction? What makes this place so cool? We take pride in saying, I'm a New Yorker. And that's the way it's always been. One thing we've all learned in recent times is that no matter what life throws at us, we face it together. And we always come through, stronger than before. We are, for the most part, good people. We come to the aid of others, willing to lend a helping hand because we care. even though we sometimes get the impression we don't. At NYU Langone, we're here to care for our fellow New Yorkers and for everyone who needs us. That's what we do. That's what we love to do. What brings us here? To this place with the coldest winters and hottest summers? We don't come here to retire. We come here to live, to be challenged, to be inspired. This is a city that demands fresh thinking and duly rewards it. If you can make it here, well, you know what they say. We New Yorkers, we're always pushing ourselves to be better. No wonder this city gives us the best of everything. You don't have to look far to see it. It's all around us. The best food, the best music, the best medical care, the best train station. At NYU Langone, we're collaborating on every level to be the best we can be for New Yorkers and for everyone who seeks our care. After all, we're New Yorkers too.
Welcome back to Women's Health Watch. For those of you who are just tuning in, joining us today is Dr. Stelios Viennas, and we are speaking about osteoporosis. You know what we didn't bring up? We didn't bring up smoking.
Very important. Smoking definitely is an inflammatory process, and anything that's chronically or anything that's inflammatory can cause bone loss.
But smokers tend to have osteoporosis.
Absolutely.
And how much time after you've quit smoking can you estimate your bones can get stronger?
I would say 2 to 3 years.
2 to 3 years. So smoking cessation will help you build up your bones in 2 to 3 years.
Definitely.
So stop smoking if you don't want to have a hip fracture. Another reason. If you live long enough to have a hip fracture, if you're smoking.
Exactly. The other issue.
The problem.
The other issue would be also sleep apnea.
So what is sleep apnea? Who gets it, and how can you figure out you have sleep apnea?
So sleep apnea is an irregular amount of sleep or irregular type of sleep, where basically the patient, not knowing it, wakes up at night because he's snoring so much, he or she is snoring so much, and is unable to sleep, to have a stage 4 sleep.
They are asleep at the time, they just don't get into stage 4.
Yeah, correct. So patients who are affected by sleep apnea are patients who are smokers, patients who are obese, who have other chronic diseases as well, and a lot of these patients don't know they have it. In terms of how they feel and why they know that they have sleep apnea is because they feel very tired during the day, they're sleepy all the time, they're not able to really carry on their tasks throughout the day. So this is one way of that symptoms present in terms of sleep apnea.
So to summarize the sleep apnea, people are tired, they don't feel rested in the morning. Sometimes whoever you're sleeping with tells you you're snoring, and that's often a sign. Patients ask me for a sleep apnea test because they keep their
Right.
partners awake. Weight can affect your sleep. If you're overweight, you're likely to have sleep apnea. And genetics, right? Some people are just genetically programmed.
As sleep apnea can be a problem with cardiovascular diseases, you know that, and hypertension, it's the same thing with bone density, because it creates basically a dysregulated bone remodeling, because it's sort of an inflammatory process, just like with cardiovascular disease, and it can affect bone remodeling and bone growth in that way.
Okay, so in summary, you can prevent osteoporosis with diet, exercise, not smoking, right? Get screened to find out if you have osteoporosis. Be aware that certain conditions will predispose you to osteoporosis.
Exactly.
There are definitely treatments that can partially reverse or fully reverse or stop it from progressing, that most people tolerate them pretty easily. And ask your doctor for a vitamin D test, a bone density test. Ask your primary care doctor, whoever your gynecologist, it could be your gynecologist. Right. They're also important in that. And any message to the viewers, doctor?
Get screened. That's what I would say.
And get moving.
And get moving.
And take vitamin D.
Yes.
And eat greens.
And eat greens,
and
yes.
don't smoke.
Just everything good.
Right, everything good. And everything in moderation, as the Greeks say, to pan metronariston. And thank you for joining us, Dr. Viennas. That was wonderful information. I hope you come back soon and teach us more about rheumatology.
Thank you very much, Dr. Kosta, for inviting me. I'm glad that everybody knows more about osteoporosis now. And I am here in Queens. I'm available to see patients.
Where is your office?
It's here in Astoria, actually, 3802 31st Avenue.
And it's Viennas, Viennas.
Yes.
That's all we have time for today. Please join us again next week on Women's Health Watch, brought to you by NYU Langone Medical Center. I'm your host, Dr. Eva Kosta. See you again next week, same time on New Greek TV.
More than 8 million people live right here. 27,000 of us for every square mile. That's a lot of people. What makes this city such an attraction? What makes this place so cool? We take pride in saying, I'm a New Yorker. And that's the way it's always been. One thing we've all learned in recent times is that no matter what life throws at us, we face it together. And we always come through, stronger than before. We are, for the most part, good people. We come to the aid of others, willing to lend a helping hand because we care. Even though we sometimes get the impression we don't. At NYU Langone, we're here to care for our fellow New Yorkers and for everyone who needs us. That's what we do.